Hi, everyone. Justin Leader here. I wanted to thank you for joining me today to discuss one of those topics that is front and center in our lives, healthcare. And it's the hottest topic in politics. It's something that impacts each one of us, our families, and in the most intimate of levels. As an employer, this is one of the biggest concerns each year, not only from a budget perspective, but more importantly, from the perspective of the health and well-being of your most important asset, your employees, and yourself included as an employee of your organizations. It is uniquely American that over 160 million individuals in our country depend on their employers for healthcare coverage. In this, it also creates a tremendous financial burden and places the employer in a very peculiar fiduciary role to oversee these benefits. For sake of time, I'm going to hop into the presentation, give you an overview of how we see healthcare across the United States, and then delve into some trends that we see as important, while there are many, many more that we can talk in regard to. I picked these few, that of which, if you have other ideas, topics, questions, concerns, things you've been told, by all means, feel free to reach out to me and we can discuss those. I also picked a few pitfalls that I think are something that all employers should be aware of as they delve into their benefits for each and every renewal. What qualifies me to be here speaking to you today? We are a niche benefits advisory firm and brokerage firm that does some unique things from an administrative perspective. BDS, our firm, we are known as innovators in the health and welfare benefits industry, and we are working to drive systematic change in a grassroots effort in the U.S. healthcare system, starting with employers who are driving change a lot quicker than policy at the government level. We've created a few unique opportunities in both Transparent Health as well as the KISS Card program. We are a multi-generation family-owned business, and while we're based in Mechanicsburg, Pennsylvania, we work and consult employers, captives, brokers and consultants, TPAs nationally. We're involved with quite a few organizations like the Health Rosetta Institute, which I just spent some time in Dallas last week at their annual summit. Highly suggest watching on the horizon for things that we are doing collectively as a few hundred consultants across the nation. Myself, I'm also heavily involved with SHRM, as well as have acted in an expert witness fashion regarding court cases that involve self-funded healthcare benefits. That being said, there's a few major issues that I see in the healthcare system. The largest problems being the following. There is a zero transparency when it comes to the cost and pricing mechanisms for most of your procedures and services across the board. Think about it from the aspect of everything else that you do in your life. Where you purchase something, is there anything you can think of where you purchase something without knowing the starting price? Looking at Amazon, for instance, you can shop quality, value, different specifications for, say, a TV that you want. However, in healthcare, we're very limited to knowing what that starting price is. There's also a lack of affordability that's hurting not only employers, as healthcare is their second largest overhead expense, but we also contend on the employee side with difficulty in employees being able to handle or be able to afford out-of-pocket expenses for even common procedures and services now. Interesting note, which is quite scary actually, in 70% of medical bankruptcy cases, the patient actually had health insurance, which is troublesome. And we have some information that I'll be sharing with a few slides and studies to show what the impact of that has been on the health and well-being of most of the U.S. population. We have a major healthcare illiteracy problem. We don't know what we don't know. How can we be smart consumers without the knowledge to be one? We'll talk a little bit about that. And then we have probably the biggest factor that has led us to where we are today. The healthcare industry is chock full of misaligned incentives. This includes inflation of prices to create a discounted network that creates the illusion of value, PBMs that hyperinflate pricing to create revenue spread, hospitals that work in conjunction with insurers to create egregious base pricing with really no basis, and last but not least, brokers and consultants. They get paid by all of these entities I've mentioned, while at each renewal increase for you, the employer, you in turn hand them an increase in their compensation. Not exactly fair, right? Which has led us to be in the situation that we are now, where our expenses have ballooned beyond $3.65 trillion annually and continue to grow to upwards of what is expected here in 2020, almost $4 trillion in spend. This graph at first may be a little bit misleading, but this is comparing our US healthcare spend to that of the gross domestic product of other nations. So we spend more on healthcare in the US than the revenue for many developed nations that we compete with out in the marketplace. I have to agree with Warren Buffett, who said it very well in an article a few years ago. General Motors is a health and benefits company with an auto company attached. In fact, it spends more on healthcare than steel, just as Starbucks spends more on healthcare than coffee beans. How's that impacting employees? Well, maybe your second largest overhead expense as an employer, but employees are feeling the pain also. This is in regard to them taking home less wages due to everything that healthcare has done to consume any disposable income that they have, as well as add a pretty substantial risk of liability on their spreadsheet. In that, high deductible health plans have led to a furthering of this issue, impacting the health and well-being of employees nationally. This slide depicts what happens when we cost shift without going after the root of the problem. Now more than ever, people are avoiding care due to lack of affordability. Keep in mind, the average out-of-pocket expense nationally for a family, anywhere from $5,000 to $6,000 per year. And that same family has, on average, about $800 to $1,000 in the bank. They're walking around functionally uninsured in a lot of ways and are one slip, trip, or fall from incurring medical debt or, worse yet, bankruptcy. So care avoidance not only impacting due to affordability, which is a huge issue, but it also impacts productivity. In addition to productivity, it's also impacting life expectancy. So we live under this mindset that the U.S. healthcare system is above and beyond everybody else. But one of the things that I'll kind of reiterate throughout this conversation today is you sometimes have to question where you're hearing that information from. So here is, up until 2018, a snapshot of our costs per capita compared to other developed nations and life expectancy, which for the first time in the history of the United States, we've had a substantial drop in life expectancy. I'll have to update this graph just so you're aware. In 2019, we saw a reverse in this trend. Most of that, which was due to a better response to the opioid epidemic and prevention of things like accidental overdose, which has helped to curb what has been a catastrophe nationally affecting all race, colors, and creeds. In regard to quality, we're actually ranked 28th in quality, and then in the world, I think we're 44th or 45th regarding life expectancy at this point. Not only does it have a large national impact regarding these costs and these expenses, but we're also extracting dollars out of our community without providing any value. You know, the range varies depending on the study and research that you see, but there's a large percentage of this spend on healthcare that can be attributed to things like fraud and waste. But more so, in my opinion, I think a lot of it has to do with abusive and arbitrarily high prices. And we'll talk a little bit about some mechanisms that you can put into place in your health plan in order to curb that. There is a tremendous amount of fraud that goes on that happens behind the scenes in all levels of healthcare, including inappropriate billing practices, as well as things that in many other industries would be considered illegal, but they continue to transpire today. We also have a major issue with misdiagnosis, mistreatment, and overtreatment for many procedures that are all too common, some of which are reactionary from a defensive position with providers that would rather overtest than not test at all. And then we also have what I call overutilization and overprescribing because of our fee-for-service mechanism for payment for a lot of providers and physicians that we have in the system and has developed over years. There's a tremendous amount of waste in insurer or care provider administration and overhead. Anybody that has ever gotten a balanced bill, either for themselves or one of their employees, has encountered this. It is a nightmare to get those bills straightened out and a complete and total headache. Last but not least, about a quarter of every dollar is really going to high quality provider healthcare. The burden for employers is roughly about half of that spend, 1.5 trillion each year, not including that of the employees. However, many employers are driving a dramatic change regarding how they purchase benefits. There's really a lack of infrastructure and frankly education regarding what can be done to make those appropriate choices in building out those benefits. And a lot of that comes down to advisor relationships, as well as vendors that have capitalized on the way the system has been built, to some to their own fault and their own doing, but many just not realizing the impact that the current system has on everybody in the economy. So cost of healthcare benefits has created a 20-year-long economic depression. Boomers have seen what should be $1 million nest egg crushed by healthcare costs. I firmly believe that this is the next housing bubble, and we're experiencing it right now, and it is unsustainable. On the lower level, most advisors in the financial space are suggesting that couples will need $250,000, $250,000 in retirement alone for medical care. To boot, healthcare literacy is a major issue. So in 2017, the Centers for Medicare and Medicaid Services did a study regarding the ability for common folk, for the U.S. population to understand basic medical terminology, as well as a basic understanding of one's health insurance plan. And ultimately, what they found was it's roughly around 12%. And for us, we decided to try to get people to act as consumers. However, we haven't given them the appropriate tools to be an effective consumer in the current healthcare landscape. So ultimately, you have individuals that are either not understanding quality versus cost. They don't have the tools. They don't have an advocate. For any number of reasons, it has become a slippery slope for the employee or, John Q. Public, but more so for the employer as well. I have to quote Dave Contorno, who's in our industry. He said it great once. It's like we've given each employee the keys to a helicopter, but we've never instructed them how to fly the helicopter. We've just said, hey, here you go, and onward and upward. Once they've paid their toll, which is their deductible, Then they're on the highway to elective surgery, visits they maybe put off, so on and so forth. The good news is there's quite a few people in and around the industry that are advocates that are working to fix a lot of these major issues that we see. Mark Bloom with America's Agenda stated this past week in a conference that I attended that he is a lifelong learner and a thief. If you give him a good idea, he's going to steal it. And I have to agree and echo with that sentiment. There are many in and around the industry who are making waves with sensible solutions. The best consultants are not continuing on the path of what we call our traditional healthcare delivery. They are truly bringing value with the innovations that they are offering to their clients and in turn their employees. America's Agenda, who Mark Bloom oversees, is a national healthcare alliance that brings together labor unions, businesses, healthcare providers, policymakers, with a common commitment to create smart policy and effective action to advance the mission of affordable, quality, readily accessible healthcare for every American. My point in Mark is this isn't just occurring with small employers. I think small employers play an intricate part in this change, but their organization is representing millions of lives. If you want to continue to delve into the forefront of the industry, I encourage you to follow a lot of the great advocates that are out there. I have a list of folks I follow and happy to share that. If you're interested, just reach out to me with my contact information at the end. Happy to pass that to you. This gentleman here is an advocate in so many ways. Dr. Marty Makary, I had the pleasure of seeing him speak last week, and he brought up some disturbing points, but some good points regarding our system. One, we don't have a healthcare crisis. We have a pricing crisis, which I couldn't agree more with. Healthcare exists in a non-competitive marketplace. I'll get into that a little bit more. 64% of people don't seek care because they are afraid of the bill, which plays into some of the trends that I'll speak about here a little bit later. Marty has written some fantastic books. I encourage you to pick them up. He is a practitioner of true value, which is quality divided by price. In addition to his books, Unaccountable and The Price We Pay, which just came out, he has worked on Fox's television program, The Resident. If you haven't seen it, you'll see a lot of what Marty preaches embedded into The Resident. Dave Chase, the head of the Health Rosetta Institute, is also involved in some of the writing for that as well. One of the things from an advocacy perspective that I respect the guy, he's not only working with CMS and HHS and the White House in a bipartisan effort to stop this healthcare bubble, but he's also going after folks that aren't doing a justice to what they were built for. In particular, recently he assisted one Virginia hospital in ceasing their pursuit of lawsuits with almost 26,000 patients that had outstanding medical bills. From a healthcare policy perspective, I like to share this example. We have been involved and founded a service called the Keep It Simple Surgery Card, where we have eliminated a lot of the go-between, the administrative fat, if you will, to offer accessible, high-quality healthcare. This came to a head here over the past year as we were recognized by the Department of Health and Human Services, CMS, and the White House regarding this big push for pricing transparency across the board for all medical services and procedures nationally, which most developed nations have transparency, and they have a cost containment mechanism to not allow some of the egregious pricing that we see occurring across the board in our country. We are also talking and doing some work with the Sanders campaign, just on both sides of the fence. It's a bipartisan issue, right? Healthcare. It is a hot topic. But I have to state that whether you are for a commercial private insurance market or you are for Medicare for all, unless we have transparency in pricing, as well as some sort of mechanism to limit what can reasonably be charged, we're not going to have a true capitalistic and competitive marketplace to compete, not only on price, but more importantly, and what we lack on quality. So here's this executive order requiring all hospitals to show exactly what their pricing is so that we can all be better consumers. And that fixed everything, right? No, it's gotten stalled. We have seen an influx of lobbying dollars in response to many of these efforts, fighting to continue to keep things the way that they are. And unfortunately, it's a battle that will continue on the political stage. However, I believe that a grassroots effort has been underway for many years, all the way back, I'd say as far as 10 years, with the addition of reference-based pricing as a mechanism for payment and cost containment for employers, to now what we see are thousands of employers coming forward with creative ideas to protect their assets, including their most valuable asset, their employee. That being said, a little disclaimer. I know it creates a pretty grim look on what's going on in healthcare, and many people get angry, rightfully so. We've all had our frustrating experiences. My wife this morning went in to see her doctor, and she texted me. She arrived there at 8:40 a.m. for an 8:50 appointment. She saw the doctor at 10:05 after a long wait. He was out of that office by 10:08. That's not really quality, right? That's just a fee-for-service business. So there are lots of folks, like I said, working to fix these issues: advocates, consultants, vendors, etc. Please note, these folks that are in some of these other entities are not bad people. A lot of them are friends, right? They're colleagues, they're peers, people we've depended on for years. However, healthcare is the second largest employer across the United States, second only to government. This is a system that wasn't built overnight. It took some time to build. It'll take some time to dissect. And those folks who have grown up in the system, I use the analogy, if you grow up in a box, you don't know there's a box. So we're helping to flip that script and educate folks on what is available out there and go back to driving capitalism or true capitalism in healthcare. All of these entities these larger entities are trying to turn the ship, but it's like the ship, the Titanic. They're trying to avoid that iceberg, which is that bubble, which is approaching. And some are doing a really great job, others are not. But if you want to see where a lot of folks are making money, there's a few players that I'll talk about: PBMs, insurers, etc. And all you have to do is look at net profit for some of these folks, including stock price, to see the amount of money that's being made. But are we really getting the quality that we would come to expect from any service provider? So what we're going to do in this is focus on the cost, what employers can do in fulfilling their fiduciary responsibility, in focusing on parts of the plan that matter most. There are many folks out there doing a great job, and it takes a village. This is why partnering with the right firm and vendors is mission critical, first and foremost. You're only as smart as the folks that are feeding you the information in a lot of ways. So now more than ever, yes, relationships are important by all means, but there has to be value there. That's part of the reason we work with other consultants across the country. A lot of consultants absolutely care for their employers and in turn their employees. That's their lifeblood. However, they just don't know what's available to them to make some of these changes. As you're evaluating your contracts and the people you're working with, keep these thoughts in mind. Cost shifting should not be the focus and has to be off the table. Cost shifting does nothing. It's just a Band-Aid, a temporary solution that will come back and rear its head. Timing can be a problem. You can't be making a lot of dramatic changes when the costs are going through the roof and during contract negotiation. There has to be a clear-cut vision in advance of these issues. In working with your consultants, I highly suggest making sure that you have a multi-year plan in place with some flexibility. My advice as well for those on the call is to form a continuous partnership of innovation and an evolution into an ecosystem that's conducive for your business as well as your employees. My 3 trends to keep an eye on and 3 pitfalls to avoid, which we'll delve into. Number 1, you need to focus on the right cost when you're looking at the pie, specifically if you're self-funded or moving towards a self-funded arrangement. There's steps that you can take to get to that place. However, in a fully funded arrangement, you have no transparency and you are at the mercy of the insurance carrier. Self-funded arrangement, you have to look at it from a different perspective. You still have protection in individual stop loss as well as aggregate stop loss. Think of it as a way to have transparency, but you can also have protection. Healthcare trends that you need to know, we're going to talk about direct contracting, we're going to talk about independent claims oversight, and then we're going to talk about employee advocacy and engagement, and then we're going to talk about a couple pitfalls to avoid: chasing of rebates, captive arrangements, and then probably one of the biggest that I see now is HIPAA compliance and compliance to your plan. Like I said, there's a lot more pitfalls. There's a lot more trends to keep an eye out for. However, these are ones that I think make sense for the time being. More than happy to delve into other things that you're seeing and hearing in the marketplace. Please feel free to reach out. So in regards to direct contracting, ongoing research into the most effective methods for reducing healthcare costs include price transparency as a primary component. More than half of U.S. employers, and I would argue more, are on board with the idea of empowering their employees to shop around for the best value and care. They just need the right tools in order to do the job. The goal is to drive down costs by steering employees in need of care toward a fair price, high quality facility. Employers can take the first step with a strategic plan design, but even within networks, facility charges can vary by over 1,000% for the same procedure. We've seen variation in our work with, say, the KISS card of anywhere from a charge of 4 to 16 times what Medicare will allow. Other strategies like making medical pricing data available to employees is another step towards driving consumer awareness and behavior, but studies show that simply doing that, providing access to data alone, doesn't impact plan costs. For example, the data tells me, I'm well aware that I shouldn't eat those wings and drink a beer on a Friday night, but I do it anyway, right? If data is available, you have to take an active engagement in that data. And there's a steerage component that comes with that. In addition, costs for more common procedures, imaging, things like high dollar treatments like infusions can also vary drastically, sometimes up to 1,000%. With no consumption or price management in place, your company, every employer, risk overpaying on both small and large claims. This is mainly because that almighty discount that we chase in utilizing a carrier network becomes irrelevant when care is occurring at a high cost facility. I go back to the analogy that we have all purchased a vehicle. We're not going to do it if we don't know the starting price. And even if you tell me that you're giving me a 20% discount on said vehicle, the fact that I don't know the starting price doesn't really tell me if I'm getting a good deal or not, especially when those base prices are inflated in the way that they are. This is why managing the price should supersede the discount in your current self-funded environment. For those moving from fully funded to self-funded, there's some steps that you can take to get from point A to point B, which will allow you to do this in a very positive and I would say rewarding financial matter. So common examples of what we see in the marketplace regarding what we call fair and reasonable pricing for procedures versus what a paid price was, even with the network discounts applied. Once again, discount doesn't mean anything if you don't know the starting price. So just by virtue of establishing a direct relationship with a provider, which providers, a lot of the independent providers, which have been bought up and consumed, have been frustrated with the reimbursement and the monotony and ridiculousness of billing, as well as chasing down out-of-pocket expenses for employees, as well as waiting for that 3-month reimbursement. So across the country, as I said earlier, it's not that we have the highest quality of healthcare. We have the highest quantity of any developed nation. So let's take surgical procedures, for instance. There's a lot of empty beds across the country. Those folks want to see patients. They're also willing to deeply discount and compete for the best price for those procedures. So it is with the footprint of ambulatory surgical centers in this instance that are out there, as well as imaging centers, there's no reason that you should be overpaying for any procedure when you have options available to you, as well as vendors out there that can help make this as simple as possible. But these are all actual pricing and charges. And I pulled a snapshot of a couple common procedures here in our backyard, going back to the KISS card, which we developed, that are all too common. The items like a colonoscopy, an MRI of the abdomen, more of your higher volume procedures, those add up over a while, but we see more often than not some pretty crazy pricing, even going through your Bucas, your Blues, United, Cigna, Aetna, Humana. Mind you, there's not that many insurers left. They've gobbled each other up. We have some regional players, but ultimately the pricing is not attractive as it once was. So if you are a carrier, you depend on your network discount. You are teaming up with hospitals to show value in your discount. A good way to do that is by inflating the charge master. And if any of you have seen the Adam Ruins Everything video, I highly suggest Googling and looking up on YouTube, Adam Ruins Everything, Hospital Charge Masters. Watch that video. It's a good explanation of why pricing is the way that it is. These bundled arrangements, for instance, in direct contracting, you can do this with direct primary care, you can do it with imaging, you can do it with dialysis. Last week, I had the opportunity to talk with Lee Lewis of the Health Transformation Alliance, who's working with some Fortune 50 companies, and the head of the American College of Cardiology regarding doing bundled surgical arrangements regarding cardiovascular episodes. These, in my opinion, this is low-hanging fruit where you can provide value. Now, a lot of folks say only large employers can do things like this. I would beg to differ. Large employers are really good. If you look at like an airport, they're really good at making control towers, and small employers are really good at making runways. Smaller employers are best suited to go out and do the bird dogging to find those providers that are willing to work with transparent open networks. Large employers can then bring in the purchasing power to support this effort. Every employer, in my opinion, has the ability to direct contract, and there are some certain things that you should look for in a direct contract partner. Those things, I had to laugh. I was thinking today about partners, and I'm like, oh man, there's so many great partners out there: Batman and Robin, Mork and Mindy, Sonny and Cher, Laverne and Shirley. So hopefully you appreciate my humor. But if you're looking to partner with a vendor that does direct contracting, you want them to be able to do a couple key things. One, they should have proven direct contracting negotiation and setup experience. This is from soup to nuts regarding contractual amendments to your plan document as a fiduciary. All these other vendors waive fiduciary responsibility. You sit in the driver's seat to drive change within your own plan to the benefit of your plan and your plan participants. In that comes some contractual wording that needs to be taken care of. Data analytics that determine direct contracting viability and effectiveness should be a component of that. So from a reporting perspective, financially, let's prove the ROI. There's many ways to do that on the get-go up front from an audit perspective to see what you could have saved, as well as call volume reporting to see how active the engagement is. I think it's mission critical to work with case managers or registered nurses regarding any of these vendors that are out there to be able to assist these patients, your employees, through these processes, which are extremely confusing in some instances, but don't need to be. We need to make sure that your claims reimbursements embed with stop loss so that you're getting any large claims applied towards specific and aggregate. As well as, more important than ever, as you're going down the path of vendor selection with any vendor, make sure their pricing is transparent. Not a percentage of claims or percentage of savings, which you can manipulate whatever that number is, but more so a one-time fee or per employee per month, which is straightforward. Healthcare trend number 2. Oversight and administration outside of your carrier administrative services only contract. Self-funded plans offer employers fewer fixed costs and more control over that variable claim spend. As we discussed, this opportunity, you can't overlook that. It's significant. Depending on the size of the company and the claims experience, claims can account for upwards of 90% of total spend. As with any other variable expense, your company's claims require tremendous oversight and alignment with what your organization is seeking to achieve. In many of your arrangements, your traditional self-funded arrangements, you almost have the fox guarding the hen house in a lot of ways, where you're not getting either access to your data, or it's not the most clear and concise data to see where a lot of your claims are coming from. And data is great, but if you can't take action in working through that data to come up with reasonable solutions, then it's a wasted exercise for everybody. Also, that data is critically important each and every year when you go through renewal. So most administrators, carriers are limited to the basic functions of claims administration. They really just ensure claims are paid timely and apply whatever the discount is. So boom, claim hits, 25% discount nailed to it, and then it's paid quickly. Companies really, now more than ever, accessing relatively the same discount on procedures, making them meaningless criteria for evaluation with healthcare partners. The BUCAs are all working in the same inflated price structure, allowing for the illusion, if you will, of a discounted deal on pricing. In contrast to that, active claims oversight finds additional savings both before and after care is rendered. The process involves things like individual claims audit, negotiation, proactive support for high-cost claimants, which everybody has on their plan for the most part. These simply aren't functions that legacy insurers and carriers are built for. By focusing on things like smarter technology and human expertise rather than discounts and auto adjudication, companies typically outperform average per employee per year cost up to 14% in additional savings beyond the network discount. And I would argue, as you have these folks, these independent third-party administrators that are flexible, you can embed other programs like direct contracting or dialysis, direct contracting or repricing, or independent pharmacy benefit managers, PBMs, that allow for even more savings above and beyond. I would argue 20 to 40% on average with an appropriately built plan, but more so allowing you to be able to oversee and protect your plan from catastrophic claims and any exposure, but you know what's going on, as opposed to in a fully funded plan when you really don't know what's going on behind the scenes, or you have limited knowledge on why you just got nailed with that 10, 20, 30% increase, in some cases even more. From an independent third-party administrator perspective, as I said, there's a lot of increased claim oversight. There's transparency regarding data reporting, as well as better terms and conditions that you can negotiate. You really want to partner with an independent contractor administrator who does not own provider contracts or is leaning on another vendor to provide those provider contracts from a direct relationship perspective. A lot of the carriers rent their networks, which there's some good and bad in there. If it's one way to find out relatively quickly who their client is. If you come up with a creative idea and they say, well, our network won't allow it, well, they're working for the network, and to protect that network, ultimately they should be protecting you as the fiduciary for these plans. You want the claims review TPA to be able to have a determination of eligibility, coverage, and liability with limited auto adjudication. You want to be able to have other protocols in place, like high-cost claims management for things like I said, imaging, dialysis, surgery, KISS card, whatever. and then negotiation and review of high dollar medical and RX claims. You wouldn't believe things that slide under the radar that are billed to a health plan. The common one that we've seen in the industry is a Care Comfort device. Some hospitals allow the staff to go down and purchase a teddy bear and then give it to the patient as a comfort, quote unquote, device. We've seen a teddy bear billed for $500 on the plan. You also want to be able to evaluate alternative treatment options. This is where Care Concierge comes into play. And then claims prevention through case management and provider steerage. Here's a genius idea that I'll steal from Adam Russo of the FIA Group. He started and founded this ERISA firm up in Boston, and he started to pull back the layers for his few hundred employees regarding his self-funded plan, and found that there were two local hospitals that both had great quality outcomes when it came to delivery of babies. One, however, all in was over $20,000 for a delivery. The other one was around $8,000 all in. So he develops a voluntary program that he communicates to the employee population. If you have your kids at this facility, we are going to pay for your diapers, wipes, and formula for the first 2 years of that child's life. Now, as a father with a infant at home, that's a big deal, right? That gets your employees' attention, and you have them going voluntarily to another location that saves your plan and them, because there's commingled funds in there, a lot of money. Healthcare trend number 3. We all could use a friend, right? Who didn't like the Golden Girls? A friend and a confidant. Advocates. You're going to see more and more advocates offered as a part of the services being provided by vendors. I can't stress to you enough, with the confusion and lack of healthcare literacy that's out there, having somebody that you can call to ask a question is of the utmost importance. Comprehensive support strategy helps employers and employees save by encouraging smart consumption. Instead of leaving employees to shop for healthcare or understand plans themselves, companies are providing concierge level advocacy services that connect employees to advocates, or they're sometimes called navigators or RN case managers. This means that employees can call before a procedure, they can ask about pricing options, they can ask about a bill that they got, a balance bill. I'll take an example of a gentleman that called in last week that received a bill. He went to a provider and they told him that it was an in-network provider, and then they billed him as an out-of-network, and he got a bill for $500. And he couldn't understand why. And we had to go back and work with that provider to reprocess this claim. And that happens more often than not. And that's not a reference-based pricing plan. For those that know what reference-based pricing is, that's a traditional PPO plan. So there's plenty of advocacy that can take place, as well as appropriate steerage to plan resources. These vendors also, for the most part, will do this in real time. So employee can pick up a phone, they can, text somebody, they can email. However, they communicate. A lot of these vendors are meeting the employees where they need to feel comfortable to share in their experience, while ensuring that the employee understands this isn't Big Brother-ish, right? We're not doing unneeded oversight. Take, for example, at BDS, we have our brokerage and consulting services, but we also have administrative services in-house for like HSA, FSA, COBRA, medical expense reimbursement plan claims, and for like the KISS card, where we decided to have RN nurse case managers on staff to assist with medical issues that groups may have. Lastly, a key component here, your HR departments feel the impact. Organizations report a 40% decrease in time spent addressing employee questions since moving to a model that has advocates that work on behalf of the plan. A company executive, I have a quote, said, "It provides participants the information they need to best utilize their benefits." But a lot of people say, well, my health insurance provides that to me, right? My PBM provides that to me, right? Well, Net Promoter Scores tell us otherwise. For those familiar with Net Promoter Scores, the better the score, the higher it is, the better they are from a customer service and responsiveness perspective. And if you look at your insurers, unfortunately, and if you've had to call into them, it's a pain in the rear. but they actually rank lower than cable companies. And I trust me, I love calling, my cable provider just as much as I love calling my health insurer. Make sure that your advocates are also willing to be able to go out, and if you're working with an insurer or network, which most folks are, they're willing to help find solutions and answers to save you time and frustration. This could be your consultant, this could be your nurse care navigator, so on and so forth. A checklist, if you will, for employee advocacy vendors. As you can see, this is everybody's trending in this direction. They all recognize we need support, we need help. Make sure that, as much as you can, consolidate those resources into one number for employees to call in and be able to chat with those folks. There should be some sort of proactive intervention that anticipates needs, either based on data or past experience within that plan, so that they can engage employees before the point of care, before they go to that crazy expensive hospital or facility. Clear and customizable communication strategies. You may work at a college where you have one population that consumes information and engagement in one fashion. You might work for a manufacturer where those folks, they just want to go in, do their job, punch the clock, go home. So maybe it's a communication strategy focused towards their spouse who happens to read the information that comes home. Also, look for health plan solutions and partners that have that in-house advocacy for real-time employee outreach and a seamless experience. Believe it or not, when you up the customer service and improve the experience, you have folks that would utilize that service again and again. 91% of members would consider speaking with their advisor before their next scheduled procedure. 93% of members feel more confident in making healthcare decisions and benefit decisions after speaking with their advisor. From an engagement opportunity perspective, your traditional customer service scope, you're going to see that changing across the board. If you're auditing your clinical strategy, you want to make sure that the outreach that's integrated with your health plan occurs in real time. It's not reactive. Successful engagement rates with clear definitions of what's a successful engagement, well beyond just a few percent of the population. If you're not hitting that level of engagement, we need to change our strategy and be flexible and able to do that. Intervention strategies based on real-time and comprehensive stratified risk data. Detailed case reviews and independent prior authorizations, understanding that healthcare is unique to the individual. Individuals require different levels of care. Clear communication with employees that builds trust. Coordination with reinsurance on the back end, your stop loss, right, to make sure that these claims, if you do have a unique situation or a high claimant situation, that is applied appropriately. And then also evaluation of alternative treatment settings. I could go to an inpatient hospital. However, if I'm healthy, I have no comorbid conditions, by all means, I should go to an ambulatory surgical center for my procedure. I'm 5 times less likely to get an infection. They're willing to negotiate on price. They typically have subspecialists that focus on various aspects of your care. So maybe they're doing 20 hernias a week. They're an expert. You want that person operating on you. This also helps to move wellness from reactionary, hey, we're going to throw in a wellness walking program, right? And that guy or gal that eats a double cheeseburger, drinks a 6-pack every night, probably not going to change that behavior, to being more of an ingrained part of the overall well-being of the employee. I also give a talk on wellness and the change to well-being. If you're interested, I'm more than happy to share that with you as well. We all remember Pitfall, right? So those were the 3 healthcare trends that I wanted to focus on today and share with you. Now we have our pitfalls, and much like this game, there's alligators, scorpions, bats, snakes to avoid. But for sake of time, as we're butting up against the hour, I'll go through these relatively quickly, but will be available for any conversation afterwards. First off, breaking up, it's hard to do. We've all been there. Unless you're one of the select few that met your spouse early on and never had to break up. But managing and containing your pharmacy drug costs is overly complex, and it really doesn't need to be. PBMs, they should really do two things, right? They should provide value and adjudicate RX claims. However, as the industry evolves and parties demand more transparency into a traditionally obscure system, you need to have a trusted pharmacy benefit manager that you can have confidence in that your investments, your capital, and your employees' capital is being managed appropriately. Unfortunately, in this relationship, most PBMs, a lot of them have been cheating on you. Not to mention hurting other players in the system, including independent pharmacies that have been driven out of business. This is a $700 billion industry, and there are so many facets that need policy change. I've worked and discussed this at length with Eugene DePasquale, Pennsylvania State Auditor General, who's kind of championing some ideas surrounding fixing these issues. But long and short, I go back to my earlier comments. You as an employer, you can drive this change a lot quickly, and it's your money, and you should. In that, you can see how the flow of drugs currently operates in our system. And there's a ton of places and areas where these folks are making money. What I will say is that there's a couple things in your PBM arrangement that you should avoid and you should seek to move away from. A big one being rebates. Many of the arrangements out there allow for plan manipulation to drive rebate dollars. We have to be ultra critical as fiduciaries and as consultants in ensuring that there is no contractual verbiage that will allow what has gone on the right side here regarding rebates that are not 100% passed through, or maybe we're offsetting your ASO arrangement with some of those rebate dollars. However, as you can see here, a lot of these are captured in the administrative fee, which sometimes is never even reported to you. So while you're getting a check for X, it's really only a small percentage of the overall rebate. Don't chase rebates. You should have verbiage that if there is a manufacturer rebate, 100% of that rebate goes to you and there are no administrative fees. We've all felt drug pricing and the unsustainability that continues to happen there. Here's a good example of spread pricing. If you take a look at the price of Humalog over a very short timeline, keep in mind your employee during this timeline is probably paying the same copay. They really don't know what's going on in the back end, but who makes out in this equation? So if you look at this, in this instance, the PBMs, as well as insurers, are keeping a portion of that spread between average list price and average net price. So in this is once again administration and fat that's built in, but that's why you have your CVS Caremarks of the world who only generate 25% of their revenue from their standalone stores. 75% of their revenue is generated by their pharmacy benefit manager. So in your breakup, a couple things to look for and ask of your PBM. One, is your pricing arrangement truly transparent? Is it a pass-through model that aligns with the interest of the PBM and the interest of, that aligns with your interest as well as the interest of your employees? Are the contract terms, definitions, and guarantees transparent? Of equal importance to the pricing structure, we want to make sure that everything is guaranteed regarding pricing and how they establish their pricing models. Are you passing back all revenues received from manufacturers? Those rebates, they need to come back to you. And when you work with a co-fiduciary and responsible PBM, you realize a higher return on those rebates. Will you have access to independent and clinically focused oversight? That is of the utmost importance, going back to advocacy, which you should demand of your providers. How will your utilization programs increase use of generic medications? You want to make sure that they distinguish between formulary management that promotes brand medications and moves people from brand medications to generics if there's a generic alternative. It's no difference in the compound. You also want to make sure that there's oversight and ensure that things like prescription niacin or prescription fish oil aren't on the plan, which can cost employers a few $100s a month for a 30-day supply. And I can give you a list of all these as well if you request it. It's really 8 things that you need to ask. Are contracts based on a discount of average wholesale price or acquisition-based pricing for specialty claims? And can we add a 90-day retail maintenance network in place of mail order? We don't need unnecessarily repackaging fees added into the overall cost of our 90-day supplies. A lot of the autofill programs end to an overabundance of stockpiling and that's unnecessary orders. And most importantly, how are you going to educate our employees on high-value pharmacies? They're going to have to look at GoodRx and compare it to what our plan offers. Mind you, if your pricing through your plan is higher than that you're seeing on GoodRx, there's spread pricing in there. They're making money where they shouldn't. Now there's PBMs that have even better pricing than GoodRx. Pitfall number 2, captives. Captives aren't that captivating. Not all captives are created equal. Sometimes you get trapped. A couple of best practices and things that you should request before you enter a captive, keeping in mind that here's a good example. Here's some group that we moved out of a captive. And I think, as you can tell, the variation between what they paid or expected to pay and what they were planning to pay through the captive between the 2 years is substantial. So they ended up spending in 2019 $399,000 compared to the increase that they were looking to receive. But we had to move them in such a way to be able to navigate a couple pitfalls with captive plans. So before you enter into a captive, I'd request the following 3 things. If and when we decide to leave, when do I have to notify the captive? Have the broker and captive agree that they will give you more than ample time to review your options each and every year. Take, for example, the 60-day notice to leave clause that many captives have. The broker sandbags your renewal to day 59, you're going to have to pay some egregious fees in order to leave that captive. It's a pressure tactic that's horrible and should not occur, but it does. 2, make sure that you understand what they do with the capital contributions, where it's held, the end of the year, how much of the surplus is returned to the employer. If you leave the captive, what can you take with you? It's been my experience that you should keep your broker and the captive accountable towards all accounting of money. We have seen discrepancies regarding what was reported as surplus and what was actually there. Last but not least, if you're entering into a captive arrangement, make sure that you have a very firm understanding of your stop loss run-out protection. More often than not, there's no run-out protection for claims, and you as the employer may be on the hook for that time period. If there's no run-out protection, ask for a guarantee from your broker that you're going to get run-in protection from somewhere, either from a stop-loss carrier, or if for some reason no stop-loss carrier will give it to you, then ask them if they're willing to back up this move and provide you with protection over that sometimes multi-month period. They might change their tune then on putting you in a captive if you require that. Not all captives are bad. There's some good ones out there that are doing things like transparency, adding programs of value to drive lower pricing. If these are all promised, just ask for proof in the ROI. And then our final pitfall that you need to avoid, especially if you're self-funded, but really for any employer that sponsors a plan, compliance, compliance, compliance. My good friends at Devo, they whip you into shape. Dust off that plan document, go straight to where you have all information pertaining to PHI, and ensure that you have a privacy official, and within your plan document, you are abiding by the protection of all things pertaining to HIPAA. I'm privy to a few cases going on now where employees were terminated either because they were a high claimant on a plan or their spouse was a high claimant. Don't terminate your employees because they are a high claimant on a plan. Make sure that you are covering your bases, make sure that your plan document is compliant and that you are in compliance. And if you want to talk about this a little bit more, we absolutely can after this presentation. Lastly, my hope and my goal is that we can go back to a time when transparency was a part of healthcare. It's a shame that we live in a society where my aunt gets diagnosed with stage 4 cervical cancer, and her first thought isn't how can I beat this, but how can I afford this? Our future vision is to continue to educate the marketplace on how healthcare should really work in the US, which we believe is a transparent, free market, value-based system where the highest quality providers of care that operate at peak efficiency are rewarded. Our plans incentivize members by waiving out-of-pocket costs when they choose a care path that leads to a better health outcome for themselves and their families. And we've also been able to demonstrate, as many others have, among tens of thousands of members, that when you make high quality care as accessible as possible, you create a true win-win scenario for the people that really deliver, consume, and pay for healthcare. That's the providers, the patients, and the employers. I appreciate your time. If you have any questions, feel free to reach out. Thank you and have a great rest of your day.